Hello everybody, welcome back to my channel. I'm Dr. Julius Kwedi, cardiovascular surgeon, coming to you from Moscow, Russia. Today I'm presenting a curious case of acute limb ischemia. This is an 86-year-old male that presented last night with clinical signs of acute limb ischemia on the left leg, left lower limb. So the patient presented with pulselessness, pale, pain, coldness of the left limb, paralysis of the left foot and ankle, right? He stayed at home for the past 5 days, decided to warm his leg with warm water to see if his situation could improve, and lo and behold, nothing changed. So last night he turned up in the casualty department, brought in by the first aid, by the emergency team. All right, now on physical examination, the patient had pulselessness of the popliteal on the left, anterior and posterior arteries, pulselessness. On the left, just the posterior tibial artery was pulseless. The patient has a history of atrial fibrillation, AF, and in our setting, AF, atrial fibrillation, is a common etiology of acute limb ischemia, which means it's most likely his AF caused these sudden acute changes. Of course, the patient does not take anticoagulation. He has not been taking anticoagulants, which raises even more the suspicion of acute limb ischemia. And he's only been taking the blood pressure medication. He does not have a cardiac defibrillator because he has not been diagnosed with any heart block, but he does have AF. We did CT scan, we did ultrasound, we did blood workup, EKG, and on CT scan, CT angio, this is what we found. It's nice aorta there, isn't it? Nice aortic root there. Nice aortic root there. And the papillary, look at the papillary muscles in the left ventricle. And look at that, the left atria, the right atria. And look at that right ventricle there. Look at the septum. Then you see your pulmonary artery there. And right, so this is your portal vein. And all right, so on CT scan, then we see our aorta here as it courses down, and then it goes through the diaphragmatic hiatus. Right, goes through the diaphragma, and then immediately after it goes through the diaphragma, then you have the first branch, right? Then you have your celiac trunk given off. And yes, and its branches there. You have your common your hepatic proper. You have your gastric branches there. All right. So you have your celiac trunk, and then you have your superior mesenteric artery. And then after that, you have your left renal vein coursing anteriorly to the aorta, after which you have your renal arteries given off. Of course, you can see the calcific changes here and atherosclerotic changes of the aorta, with the right renal artery being given off first, and then after that you have your left renal artery being given off next. Shortly after that, of course, then you have your inferior mesenteric artery. You have your inferior mesenteric artery. Look at that inferior mesenteric artery. So it's really impeded here by atherosclerotic changes. There is some stenotic changes there at the mouth of the inferior mesenteric artery. You have your vena cava, inferior vena cava there, causing in the posterolateral 7 o'clock position from the aorta. As you continue, you have your bifurcation, your aorta bifurcating into the left and right common iliac arteries, and they are also involved in atherosclerotic changes there. Of course, and then they look like there's some aneurysmatic dilation there. Aneurysmatic dilation of the right common iliac artery, giving up, and then both iliac arteries give off they both give off the deep deep iliac artery, or the internal iliac arteries, and the common the external iliac arteries, which continue to course on all the way until they reach the common femoral artery. And on the right, you can see that the common femoral artery, it gives off the deep femoral artery and the superficial femoral artery. The right leg, there was no complaint concerning the right leg, right? And you can see a common femoral vein here between the two femoral arteries. So the right leg is not in pain, right? And you can see how the superficial femoral artery goes very nice and down. Yes, with stenotic changes some along the way, and but fairly. Of course, now down here, then you have occlusion, right? From the popliteal artery down, you have occlusive changes there. And of course, you have your anterior tibial artery and your tibioperoneal artery, and you have your peroneal and posterior tibial artery. They are all occluded, yes. But for some interesting case, given his arrhythmia, atrial fibrillation, and very, very strong pulses, I was able to feel, you could feel the anterior tibial artery pulsating. You can feel it pulsating despite as you can see, it's intact below, although beneath above there are some occlusive changes there. But when you go to the foot, the anterior tibial artery is patent and it's pulsating quite remarkably. Now, turning our eyes to the left, turning our focus to the left, you can see that immediately after the common femoral artery bifurcates into the deep femoral artery as well as the superficial femoral artery, then you see the occlusive changes. You see that thrombotic changes. You see, pay attention to this. Pay attention to that, and then you see here the thrombotic changes, the occlusive changes. This is acute thrombosis. This is thrombosis. This is a fresh thrombus from the heart that ended up in the superficial femoral artery. The good thing about this patient is the atherosclerotic changes are quite minimal. Therefore, it was possible to remove all these clots. So you can see here the occlusion of the superficial femoral artery. The deep femoral artery remains quite well intact, which kept the leg viable for all these 5 days that he has not been coming to the hospital. As you can see that given that there are no occlusive changes of the atherosclerotic occlusive changes, the patient does not have well developed collaterals. So thanks to his deep femoral artery, his leg is able to survive that long. Now, the superficial femoral artery, as you can see, continues all the way from the bifurcation, right, until the entire length of the superficial femoral artery. You can see the calcific changes here. The entire superficial femoral artery is occluded. You can see the popliteal vein here on the posterior lateral position from the popliteal artery, and all the way into the popliteal artery you can see the occlusive changes, the acute changes, acute occlusion, the thrombotic changes, the thrombus. So you have this entire thromb running all the way from this bifurcation from the mouth of the superficial femoral artery, going all the way into the popliteal artery, and then look at that. The popliteal artery gives off the anterior tibial artery and the tibioperoneal trunk, even the anterior right there, and then you see here even the peroneal artery as well as the posterior. You see here it bifurcates here. The tibioperoneal trunk bifurcates right into the posterior, and the peroneal artery. The posterior is totally occluded. The peroneal artery remains partly open, partly closed. All right, sorry, let me see. Sorry. Right, this is the posterior. This is the posterior artery here. See this? This is the posterior artery here. This is the posterior tibial artery. Yes, it's occluded. It's occluded, right? It's occluded, and then down there are some open. It's open, right? This is your great saphenous vein. This is a great saphenous vein here, but this is your all right. So this is your great saphenous vein, but then this is your posterior tibial artery, and this is your peroneal artery, and the anterior tibial artery is right there. So the anterior tibial artery is occluded. The peroneal artery is occluded, but with some open here and there, as well as the posterior tibial artery on the left. All branches of all arteries on the lower limb on the left are occluded, and there's no pulsation. So we took the patient to the OR. We did a thrombectomy. We did a hybrid operation. We did a thrombectomy of the superficial femoral artery, thrombectomy of the popliteal artery, thrombectomy of the posterior tibial artery, as well as the peroneal artery. We did not touch the anterior tibial artery. We revascularized just the posterior tibial artery as well as the peroneal arteries. We received a very good result on control angiography. There were some hemodynamically significant stenosis of the peroneal artery and the posterior tibial artery, which we then dilated. We did transluminal balloon angioplasty of the posterior tibial artery and the peroneal arteries, which gave us very good results. So the arteries, both the peroneal artery and the posterior tibial artery, were open all the way until the foot, and so we received very, very good revascularization, and the patient then was taken to the ICU. Today will be transferred back to the ward. Was taken to the ICU. The leg reperfused. We are watching out for that reperfusion injuries, the reperfusion changes, and weary of a potential compartment syndrome, given the fact that he has waited for 5 days, and therefore we'll be checking the laboratory results, his creatinine clearance, his creatinine, as well as his urine output, to see how the leg is, the body is responding to the new changes, and also checking to see if he will need fasciotomy. We did not do a prophylactic fasciotomy. We did not see that necessary, but we'll see how it will be on, how he will be on Monday. Right, that is the curious case of acute limb ischemia of an 80-year-old male that presented with paleness, pulselessness, paresthesia, paresis of the left lower limb. Thank you for tuning into this case, and look forward again in our next video. May the Lord bless you and keep you sane in this insane world. Shalom.